Hello, and welcome to our part 2 of chapter 5 of the gastrointestinal system pathology. Today we're going to start talking about some of our small bowel pathologies, and we're going to go over Crohn's disease, small bowel obstruction, Dynamic Alias, intussusception, and malabsorption disorders. When we talk about Crohn's disease, we can also call this, or it's also known as regional enteritis. Now, if we look at the terminology regional enteritis, we know regional would not include the whole small bowel. It would just be regions of the small bowel, and that's going to be important as we go forward. Enteritis is going to be inflammation of the intestines. So with Crohn's disease, it's an idiopathic chronic inflammatory disorder. They assume that possibly because some of this appears during very stressful periods of life, that it has a psychologic component. It most often involves the terminal area of the ileum, which we know is the area where our small bowel is going to cross over at the ileocecal valve and turn into our large intestines. So it's right there at that distal portion of our small bowel that we're going to see Crohn's disease of the small intestine really take shape. Okay. Now, it doesn't only occur there. That's just the most common place that we find it, the initial place. It can also move to different small parts of the small intestine as well as into the large intestine. It's most common in young adults, and like I said, it can have a psychologic component. One of the common things we see with this is, as I mentioned, with the regional enteritis, that we'll have areas that are affected, separated by what we call skip areas, so areas that maintain its normal presence. We also, with these, can find ulcerations that go all the way into the mucosal and submucosal areas of the disease, of the bowel, and that's going to be another important component when we're looking at the diagnosis of Crohn's disease versus ulcerative colitis. The appearance of this, or the sequelae of this, is usually right lower quadrant pain. It can result in fistulas. If those ulcerations go all the way through the bowel, it can open up a path connecting the bowel with a different component. Sometimes that could be the vagina, sometimes it could be the large intestine, and so fistulas are not uncommon in this. Another thing that can also happen is rectal abscesses. So that is another component that we can often see with Crohn's disease. When we're looking at the appearance of this, we can often see distorted mucosal folds. So in the small intestine, we have very small mucosal folds, and as this takes shape, you can see that those mucosal folds will look a little bit different in our areas that are affected. One of the common appearances of these, especially with a barium study, would be a cobblestone appearance, where the ulcerations kind of create a cobblestone appearance, where then the normal bowel in between these ulcerations would create the separation of those cobblestones. Another thing that can happen is over time, this can cause fibrosing of the intestine. And when we see that, we'll see a narrowing area, or a string sign, where the barium would just go through a very narrow area representing the string and then go back into more normal bowel. And last thing that we really can note is omental caking. Now, we haven't gone over omentum a lot, but omentum is an area that kind of hangs over the bowel, and it contains a lot of protective fat. When there's an infection or an inflammation of an area of the bowel, some of that fat transitions over the top of that area. That's called omental caking. So sometimes you'll see that with our Crohn's disease. Here's an example of that cobblestone appearance, where you see ulcerations creating these little cobblestones, and then the normal or more normal bowel is separating them, creating the spaces between the cobblestones. Okay, our next pathology that we're going to talk about, and one that you guys are going to see very, very frequently in the field, is our small bowel obstruction. You've probably seen this a number of times already. So Two of the reasons that we usually get a small bowel obstruction would be because there's fibrous adhesions from a previous surgery. So maybe you've had some bowel surgery and your body has developed scar tissue around where the surgery was performed. That scar tissue can get around that small bowel and almost choke it off. So that would obstruct the bowel from being able to move its contents through in a normal fashion. The other common cause of a small bowel obstruction could be a hernia. So hernias are when the bowel herniates or passes through an opening that it's not supposed to. These can be hiatal hernias where the bowel is going through the diaphragm into the thorax, or it could be abdominal wall hernias where there's a disruption in the abdominal wall. Your bowel gets through there and then it kind of gets stuck. And you can imagine this as if when you're moving a bowel through a small space it's not supposed to be in, it's going to occlude that bowel and prevent the movement of contents through. Now, a few other less common causes would be a luminal occlusion. These can be caused by a gallstone. So once in a great while, a gallstone will, a gallbladder that's very, very sick or inflamed can compress on that small intestine, and it can actually create a fistula between the gallbladder and the small intestine. And then a large stone is able to get from the gallbladder into the small intestine and occlude it. Another type of problem that could cause this is called intussusception. And what intussusception is it's telescoping of the bowel. So if we have bowel that typically goes along in a nice, normal, sort of linear fashion, that's what's expected. With intussusception, some of that bowel begins to telescope or come back inside of the normal lumen, like so. And you can see how that would narrow the lumen of the bowel and could cause obstruction. And then finally, there's some intrinsic lesions, and these could be caused by neoplasms, where we would have a mass either in the bowel or from outside compressing on the lumen, or you could have inflammatory strictures where the bowel gets so inflamed and upset that it swells and compresses the lumen or the opening. So materials are not allowed to get through there anymore. Finally, there could be vascular insufficiency, where the vessels that are feeding that bowel aren't able to meet the metabolic needs, and the bowel can then begin to die off and necrose. So here's some examples of small bowel obstructions, and usually with the small bowel obstructions, it's going to be very important to get not just a supine, but a supine and erect. And we know that with the erect image of our small bowel obstructions, you're going to start to see air fluid levels like we see here. Here you can see the fluid levels, and then you see highly distended bowel proximal to that. Now, anything distal to the obstruction is going to basically be collapsed bowel. Anything proximal to the obstruction is going to be very, very dilated. And you see that you lose some of that normal bowel folds that you would typically see in a normal GI study. The next thing we're going to talk about is our adynamic ileus. Now, adynamic would be no. Dynamic means changes. So we know that an important component of our bowel is that it's always peristalsing and it's always moving contents through. So if we have an adynamic ileus, that means that our bowel is going to stop those changes, stop that moving, and then that would cause everything to back up in that bowel. This ileus refers to an obstruction. Okay, so another name for the adynamic ileus, which is probably more commonly used, is the paralytic ileus. So that means the bowel is almost paralyzed for a moment, and then that causes an obstruction. Now, this is really common especially after surgeries. So the bowel does not necessarily like to be touched. So if a patient had some surgery and the bowel was, manipulated for some reason, and the patient was under anesthesia, it may make that bowel just stop doing its job or stop peristalsing. That would result in an adynamic ileus. With an adynamic ileus or a paralytic bowel or paralytic ileus, fluid and gas do not progress normally through the area through the non-obstructed area or the small bowel. So the causes of this, like I said, can often be due to something like surgery, or it could be a neurologic problem. So for our bowels to move normally in peristalsis, we have to have our neural system working correctly to trigger those movements. So sometimes if we have some sort of neural problem, or the neurons aren't functioning correctly because the bowel's been manipulated during surgery, we can have an adynamic ileus. Other causes can be hormonal or metabolic factors, and it will occur to some extent in almost every patient who undergoes abdominal surgery. So we'll look at these and we'll think, oh, they have a small bowel obstruction because it's going to have a very similar appearance. But what it really is a paralytic ileus. These will cause your patient a ton of pain because their abdomen is going to become very distended. They're going to be full of air, and it's very, very uncomfortable. A few other common causes could be peritonitis, so inflammation within the peritoneal cavity. That could be something that caused by maybe an appendicitis or other types of infection that has gotten loose basically in the peritoneum. Other causes could be medications that decrease our peristalsis, electrolyte and metabolic disorders, or trauma. And here's an example. Again, this is going to look very, very similar to our just general small bowel obstruction. So it's important with these patients that you're going to be noting if they've had any recent trauma or surgery or something like that to help the physician in their diagnosis. We just talked a little bit about intussusception and how it is this telescoping of one part of the intestinal tract into another because of peristalsis. So that peristalsis of the bowel actually pushes some of the distal bowel. So here's my distal bowel. It's going inside the normal bowel, and it can again cause an occlusion, or it can actually cause a lack of blood supply to this intussuscepted area. Okay. This is a major cause of obstruction in children, and it doesn't look that significant, but I can tell you from experience, my son had this, and it has very significant symptoms. So with intussusception, usually these children will have a lot of lethargy. They'll be very sleepy and tired and not very mobile. They can have bright red or red jelly colored bowel movements. So it's really kind of a scary thing. It needs to be usually addressed surgically immediately to try and prevent any of that bowel from necrosing. One of the other things with this is you might see these patients get a barium enema. And one of the ideas behind the barium enema is not just for the diagnosis of this, but that pressure of the barium coming up into the intestines can actually force them to sort of push themselves apart and regain their normal presentation. So here's an example where you see this, and you see here's our normal looking intestine, and then here is the area of intussusception where that bowel is being telescoped inside the normal bowel. This example, that it's actually occluding the bowel because you see that there's no movement of that barium from this proximal portion into the distal portion here. Here you can see it again where it is passing some barium through, but it's definitely causing some issues right in this area. So these would need to be surgically addressed if the barium enema was not successful as a therapeutic. That brings us to malabsorption disorders. Malabsorption, we're looking at the terminology here. Mal would be bad. Absorption would be, we know our intestines are responsible for absorption of all of our nutrients. So malabsorption disorders means our bowel is not properly absorbing our nutrients. There's a lot of different conditions that can cause this. Some of them can have to do with the pancreas or the gallbladder. They're not producing, or they're not providing the bile and the enzymes into the bowel in order for it to complete its absorption disorders. Others could be due to short bowel syndrome, where some of the bowel is removed, and that can be because of disease, or it could be because maybe the patient has had a gastric bypass or had some of their proximal bowel removed for weight loss results. Any of these things can cause malabsorption disorders. One of the common things that we see with this is steatorrhea. And what steatorrhea is it's oily bowel movements. So usually in our small intestines, we're going to be providing enzymes and bile to help break down the fats in the intestines right there at the proximal duodenum. And those will help break those down so that the fat is going to then be absorbed into our system. In these malabsorption disorders, that absorption is not occurring properly, and so we get the passage of that fat through the whole intestinal system, resulting in high fat content stools that float. So this is just an example of a couple different types of malabsorption disease, and you can see that they have very different appearances on our studies. The treatment for these is commonly to treat with supplements or drugs, or if the problem seems to be coming from the pancreas or the gallbladder, maybe treat those problems. So that's going to be our malabsorption disease, and it can be accompanied by a lot of weight loss as another component of this. So quick summary of our small bowel abnormalities. So we have Crohn's disease, which is our regional enteritis. This means that we're going to have areas of inflammation and ulceration separated by areas of normal bowel. That's what makes it regional. We'll have irregular thickened mucosal folds. It can show up as cobblestones if we have ulcerations. And this can be treated with medications and surgery if complications occur. And remember, with Crohn's disease, it's going to be most often noted at that distal ileus, and it is going to be common for these to create fistulas if those ulcerations are able to break through to other areas. Then we go to our small bowel obstruction, and so these can be caused by anything that's going to obstruct that small bowel. So things like intussusception, a gallstone, sometimes thickened mucus from patients that have cystic fibrosis can do this. So anything that obstructs that bowel lumen and prevents the normal peristalsis and movement of materials through that can cause a small bowel obstruction. A dynamic ileus is going to look similar to our small bowel obstruction. With this, it's paralytic. So it's a neural problem where our bowel stops its normal peristalsis and it fills up with a lot of gas and fluids. Usually with the adynamic ileus, they'll resolve on themselves, but one of the things that they can do to eliminate or improve some of the patient's discomfort is inserting a nasogastric tube to allow some of that air to decompress out of the bowel and allow them to have some relief until their bowel starts functioning normally again. If it's due to a surgical procedure, then usually within, like I said, that 36 to 48 hours, it will start functioning normally again. Intussusception is the telescoping of the bowel. This is usually in children at that ileocecal valve. With this one, we can see an obstruction caused, or we can see that coiled spring appearance with a contrast enema. Sometimes our enemas can actually be therapeutic in making these separate themselves. Then we go to malabsorption disorders, which just means that we're having trouble for some reason absorbing the fats and nutrients in our small intestines, and so you'll see a lot of those coming out the other end, for a lack of a better term, and we'll have very oily stools or steatorrhea. All right, clicker question. The most common small bowel disease is cancer. That is false. An adynamic ileus occurs to some degree in most patients after abdominal surgery. That is going to be true. Which portion of the small bowel is most commonly affected by Crohn's disease? We know that that's the terminal ileum right before it goes to become the large intestine. Now we're going to move to large intestine pathology. So we'll look at appendicitis, diverticulosis, diverticulitis, ulcerative colitis, Crohn's colitis, ischemic colitis, irritable bowel syndrome, cancer of the colon, large bowel obstruction, volvus of the colon, and hemorrhoids. So appendicitis, we know that our appendix, if we look at our bowels, And I have my large intestine coming down here. This would be my ascending colon. Here's my transverse colon and my descending colon. This is the cecum. This is right where our ileum of our small bowel feeds into our large intestine. And at that cecal area, we have our Viriform Appendix hanging off there. Now, there's some information that makes us think that this Viriform Appendix is important to our immunities. Now, one of the things that can cause an appendicitis is when we have fecal matter get into the lumen of that appendix and get stuck. And it creates what we call a fecalith, or a stone, a fecal stone. Now, when that happens, it's going to block the lumen of this appendix, and it's no longer going to be able to communicate. When that happens with the large intestines, when that happens, it gets very inflamed and can cause a lot of pain, and it can even cause a rupture. So if this causes a lot of inflammation, it can cut off the blood supply, which would cause necrosis or death of some of the wall. That could lead to gangrene, death of the wall. Now, if the wall is dying, it's more likely to perforate and allow an opening of that appendix into the peritoneum. When that occurs, it's not uncommon to get an abscess, and our body's way of protecting ourselves from fluids that shouldn't be free-floating in our abdomen is to create an abscess. So what would happen is it would set up a fibrous capsule around the area where we're having fluids come out of that necrotic appendix, and it would hold them, and it would try to contain those fluids so that they don't go throughout the whole peritoneal cavity. Now, anytime you have an abscess, you have or a perforation, you're going to have a significant inflammatory response. And so with appendicitis, you're really going to see an elevation in the white blood count. You're going to see a lot of pain in that right lower quadrant area, and you're going to have often accompanied by fever and a lot of discomfort. The interesting thing with appendicitis is when they're clinically checking for this, it would be a patient that is very, very sick with nausea, vomiting, possibly diarrhea. They would have, whether it's ruptured or not, they're going to have rebound tenderness. And what rebound tenderness is if you press your hand into your right lower quadrant, it's going to be a little bit uncomfortable. But with rebound tenderness, when you press and release, the significant discomfort comes upon release. So when your abdomen rebounds to its normal position, that's when the significant pain sets in. Appendicitis is more common in children. This can be something that's evaluated by CT, ultrasound, or X-ray. So here's an example of an appendicitis on BE. So you can see the cecum right in here. Here's our cecum, and you can really see that appendix off of the cecum here very prominently. They don't always appear this prominently, but you can see that lumen is quite wide, and you can see that it has some jagged edges. That's from the inflammation. And so this would be an appendicitis as it's noted on BE. If we look at it in ultrasound, it looks a little bit different. Usually it's difficult to see the in ultrasound, we don't usually see a normal appendix, but when they get really inflamed, the walls get thicker. They start becoming what we call hyperemic, meaning there's more blood flow through them because that blood flow is coming to fight the inflammation. And so ultrasound is a good manner to diagnose appendicitis, although it can still be really difficult to see. That brings us to diverticulosis, excuse me. So diverticulosis is going to be caused by diverticuli that occur in the large intestines. And so these are weakening of the intestinal wall, allowing a herniation or an outpouching of the mucosal layers. These can be identified on a barium enema or a colonoscopy or a 3D CT virtual colonoscopy, where they complete a CT and then they reformat the images to create a three-dimensional view of the intestines, which are able to do what they call a fly-through that will present very similar results to a colonoscopy. These are more common with older patients. So the older you get, the more likely you are to create diverticuli. The diverticuli are going to be more common in the sigmoid region, and usually they develop first in patients that have had chronic constipation or have had to strain a lot to have bowel movements. So just that straining action can cause the weakening of the walls and the creation of our diverticuli. Now with these, if these patients that have diverticuli are often encouraged not to eat things with small seeds like strawberries or other things like that, because some of those things can get in these diverticuli pouches and they can cause inflammation, which then we would call these diverticulitis. Okay. So with diverticulosis, some of the symptoms of this could be pain, bleeding, diarrhea, constipation. One of the important things is to note that they often occur in clusters. So you may have very normal bowel to a certain extent and then see a cluster of these. Here's an example of diverticulosis on a BE. So this would be a barium enema, either a single or it could have been a post-evac. And you can see here are diverticuli in a cluster. And then this bowel over here looks fairly normal. You see the normal looking haustra, but over here you're seeing the diverticuli. That brings us to diverticulitis. So this is a complication of diverticulosis. Now, because sometimes fecal matter and other material gets caught in those diverticuli, it can cause a necrosing or an inflammation of the diverticula. So something gets in there, it starts to become inflamed. We know the inflammatory process sends in a lot of our white blood cells, makes our vessels in the area more permeable, so you're going to start holding on to more fluids in that area, and it's going to cause this great inflammation response. If that inflammation response is not effective, the bowel then can become necrosing, or if it has a cutoff of its blood supply, it can begin dying. And in that case, you're at a higher risk for perforation again, because the bowel wall is dying. And that perforation can be followed by an abscess, which is, we know that fibrous capsule comes in to try and encapsulate this to prevent it from going out into the whole peritoneum. And if an abscess doesn't occur, you might end up getting a fistula to an adjacent organ, such as the vagina or the small bowel or other areas. So these are all complications of diverticulitis in addition to just being very painful for the patient. With this, on your exams, you might see if they have significant diverticulitis. This is something you wouldn't want to use your normal barium for a barium enema. This is something you'd want to go with a water-soluble contrast, because the possibility of perforation is going to be much more significant. And if they are perforated, you'd want to make sure that their body was able to absorb that contrast and not have it just sitting in their peritoneum causing peritonitis. You can also, like I mentioned, have a paracolic abscess, which paracolic means just around the colon. Okay. So here's an example of diverticulitis on a barium enema. And so they have their contrast coming in here, and then you see this string-like sign. And this is because there's significant inflammation or swelling from an inflammatory reaction in that bowel, compressing the bowel wall to be almost a string-like sign. This one does not appear to have perforated, because it seems like the contrast is staying within the bowel itself. That brings us to ulcerative colitis. Now, this is one of them that can be easily confused with Crohn's disease, but it's slightly different. So Crohn's disease can appear in the large and small intestine, where ulcerative colitis, just from the terminology and the name here, we know is only going to appear in the colon. So ulcerative colitis is an idiopathic inflammatory disease of the bowel. And again, they think that it may have psychogenic factors, meaning that it's somehow linked to stress of our psyche, which can cause an autoimmune reaction where our immune system basically starts attacking our own bodies. So it's an autoimmune disease with a psychogenic component. So it's really important for these patients with ulcerative colitis to try and contain their stress, or learn ways to deal with stress in a healthy manner to help prevent some of these autoimmune reactions. Now, a characteristic feature of this is alternating periods of remission and relapse. So they may do really well for a while, undergo a lot of stress, have a relapse. One of the problems with ulcerative colitis is that it has a highly increased risk of malignancy by about 10 times. Your patients with ulcerative colitis are going to be 10 times more likely to develop a malignancy or a bowel cancer. Patients with ulcerative colitis often have something that is called toxic megacolon. And what happens with toxic megacolon is the colon just gets very, very enlarged and dilated. And it can perforate and cause toxins to go out into the peritoneum. It can also cause toxins because they are not normally absorbing from the large intestine. So when we're seeing these patients, usually they're going to come in, they'll have bloody diarrhea, they can have fever, they can have a lot of weight loss because the absorption in the colon is not functioning properly. It can then result in that toxic megacolon where you'd see a highly dilated colon with the loss of the appearance of haustra. Another thing that you can see is hyperplastic mucosa, where the mucus of the colon becomes very, very thick. This can almost even obstruct the colon in some cases. They'll also have ulcers, just as you can imagine from the terminology used in this pathology. Now, with these ulcerative colitis patients, barium enemas are contraindicated because they can also cause the perforation. Now, if you get toxic megacolon with ulcerative colitis and then you have a perforation, this can actually cause such a significant reaction by the body that it'll put you into shock and could be deadly. If with the toxic megacolon, you'll see these patients experiencing fever, pain, increased white blood count, all of that because it's an inflammatory, infective process. Okay. Now, with ulcerative colitis, part of the battle here is trying to differentiate these cases from Crohn's disease. And with ulcerative colitis, the important note is that it's not going to affect the small intestine. If it does, it would just be the distal ileum. The other thing here is that it does not have skip areas like Crohn's disease had. So it would affect the entire bowel. Okay. It can have a granulosis or a grainy type appearance in the mucosa, and it can cause ulcers, which would cause hyperemia or increased blood flow to those ulcerative areas. And sometimes when we see these ulcers on some barium type study, the ulcers can look as something like a button. And so that can help be a diagnosis pattern for these. Ultimately, because of the ulcerative component, we know that tissues that are attacked over time, they can give up and become very fibrotic. And when that happens, they can cause actually areas of fibrosis and muscle spasm. You can lose that appearance of haustra, and you can have some narrowing of the colon in those areas. Here you see a patient with the ulcerative colitis that has affected the entire large intestine. And with this, you see some of that cobblestoning type appearance in the loss of haustra, and the fact that it's affected the whole colon, not just patchy areas, such as Crohn's disease does, is definitely indicative of ulcerative colitis. Now, if we talk about Crohn's colitis, this would be something that would, again, as it did in the small intestine, it would affect portions of the bowel rather than the whole bowel itself. So Crohn's colitis is identical to Crohn's disease in the small bowel. It can be differentiated from ulcerative colitis by looking for that cobblestone appearance separated by spared areas. It most commonly affects the proximal colon, but then spreads out through the whole colon itself, and it can sometimes cause the disease to go into the terminal ileum. So that's the one part that chronic Crohn's colitis will affect of the small intestines. The other thing about this that's different is Crohn's colitis typically does not affect the rectum as much as ulcerative colitis does. Here's an example of Crohn's colitis, and you can see that it has a lot of edema in the wall of the large intestines. It has caused a loss of hostra in the wall, and it almost has like a bitten type appearance in that colon. Ischemic colitis is going to be the loss of blood perfusion. Now, ischemic colitis could be caused by a number of different things, anything that disrupts the blood perfusion to an area of the colon. And when a patient is experiencing this, it can result in severe lower abdominal pain and even rectal bleeding, as well as diarrhea. Now, lots of times this can come if a patient actually has some type of herniation, where the bowel has herniated through a disruption in either the diaphragm or abdominal wall, and it's able to protrude through, and then it gets what we call incarcerated or held in that area, and the pressure of that can cause the pressure of that area squeezing on the bowel can actually cause it to cut off the blood supply and result in ischemic colitis. Most patients that end up having ischemic colitis do have a history of cardiovascular disease. Patients that have a history of cardiovascular disease are typically, unfortunately, building up plaque in their vessels. And if they're building up plaque in their cardiovascular system, then odds are they're building up plaque in those arteries that feed their bowels. So sometimes that plaque can dislodge and occlude a vessel and prevent the bowel from getting the blood and nutrients that it needs. So that would be another cause of ischemic colitis. Here's an example of ischemic colitis, and you see this fingerprint appearance from the lack of blood perfusion to that area is causing the disruption of the border. Next is irritable bowel syndrome. Irritable bowel syndrome refers to several conditions, so it's kind of an umbrella term, but what most of these patients have in common is that they have disruptions of their bowel habits, ranging from diarrhea to diarrhea with increased motility or lots of movement to chronic constipation. And they do think that there's a underlying pathophysiologic abnormality that causes this. Next, we'll talk about cancer of the colon. Now, we already talked about how patients with ulcerative colitis are 10 times more likely to get cancer of the colon, but that's not the only cause. Cancer of the colon is the third leading cause of cancer deaths in the United States, so it is relatively common. Its peak age of incidence is between 50 and 70 years old, and it's much more common in men than women. Some of the predisposing factors are going to be that long-term ulcerative colitis that I mentioned, or familial polyposis, and that just means some families have genetic components that allow them to or cause them to develop polyps in their colon. These polyps can over time become cancerous. So having lots of polyps could put you at higher risk for having cancer of the colon. When you have colon cancer, it can intrude or grow into the colon itself. If it grows large enough, it can cause a bowel obstruction. Lots of times, if you see a polyp that does not have a stalk, so it's kind of flat against the wall, and if it measures greater than 2 centimeters, the odds of it becoming cancerous are very, very high. This is an example of that type of polyp. It is attached directly to the wall with no stalk. It's almost compressing or occluding the lumen, and it's definitely larger than 2 centimeters. So because of this is probably a colon cancer here. Here's an example of what they call an apple core sign. And so you see that we have this narrowing of the actual lumen here, but really this whole thing is a cancerous tumor that's actually causing this narrowing to appear of the lumen. So it's almost this having mass effect on the lumen, pressing and creating what kind of looks like an apple core here. Okay, here it is on a CT exam, and so you see the large intestine here, and you see this plaque-like thickening of the mucosal wall due to a cancer here. So with those large intestine carcinomas, they try to do colonoscopies at about age 50 to start identifying polyps and removing those polyps often during the colonoscopy to help prevent the risk of cancer. If there is cancer already there, then that can identify the cancer and allow for them to begin treatment. Next, we're going to talk about our large bowel obstruction. And like I mentioned, those carcinomas can get so large in the large intestines that they can actually occlude it, causing an obstruction. So, excuse me, about 70% of our large bowel obstructions actually come from colon carcinoma. Now, diverticulitis and volvus account for most other cases. And remember, diverticulitis is when you have a diverticuli that becomes very inflamed. Anytime we have an inflammatory or infective reaction, it causes a bunch of edema or swelling. And sometimes that swelling can occlude the large intestine and cause a large bowel obstruction. The other thing that can cause this is a volvulus. What a volvulus is it's a twisting of the bowel, which would cause it to obstruct. Just like you might twist a hose to stop the flow through a hose, the same kind of thing can happen with a large intestine. Twisting it can cause an obstruction. Usually our large bowel obstructions are less acute than small bowel obstructions, so they develop more slowly. It doesn't just happen in a moment and then correct itself quickly. So the symptoms develop more slowly over time, and with the large bowel intestines, we also have fewer fluid and electrolyte disturbances because most of our fluid and electrolytes are actually absorbed in the small intestine. So disruption of that small intestine can be very significant, whereas the large bowel obstruction will not affect the absorption of fluid and electrolytes quite as much. Here's an example of a large bowel obstruction, and sometimes these large bowel obstructions can almost look like a kidney-shaped area of bowel gas. Now, many of these can occur right at the cecum, and if they occur at the cecum, they have this habit of actually moving upward and toward the left of the patient. So this is an example of a large intestine obstruction where there's a lot of gas here in the large intestine, and it takes on that kidney type shape. Volvulus of the colon, like I just talked about, is when the colon actually twists on itself, and that can cause the obstruction. Most common sites of this are at the cecum or the sigmoid, and again, this can cause that cecum especially to become elevated at the patient's left and have that kidney appearance. Here's an example. Sometimes they will call this a beaking sign. So this colon is twisted upon itself. They've provided barium through into this colon, but you can see where the twist occurs, you get this beaking sign from both sides of the twist. Okay. Now, sometimes a barium enema can actually be therapeutic in this and cause the bowel to untwist itself because of the barium in the enema. Next, we'll talk about hemorrhoids. So hemorrhoids are varicose veins of the distal rectum. Symptoms of these really include pain, itching, and bleeding. Lots of these develop when our valves of our veins in the rectal area become incompetent. One of the things that affects valve competency is pressure. And so things like constipation, pelvic tumors that increase abdominal pressure, and pregnancy that might cause a patient to have more straining during bowel movements could cause the creation of these hemorrhoids. Once you have hemorrhoids, it can be very difficult to get rid of them. Lots of times they're really just treating the symptoms of the itching and swelling of these rather than treating the hemorrhoids themselves. There are a couple different approaches they can do to get rid of hemorrhoids. One of them is a banding type approach where they put sort of like rubber bands around the hemorrhoid, which would basically cut that area off over time. Another one is actually a surgical removal and repair of the area. Hemorrhoids can cause a lot of bleeding during bowel movements and things like that, so they can be a significant issue for some patients. And remember, you're at risk if you have like a strenuous job. Maybe you're a weightlifter, maybe you lift heavy things all the time, or you have to strain frequently to have bowel movements. Here's an example of hemorrhoids on a BE. And so here you see the barium enema tip in the rectum, and you see the rectum is filled with air. And you see these lumps pressing into the rectum. Those are they are displacements of the normal tissue by dilated varicose veins or hemorrhoids. Okay, so really quick review of our findings from the colon. We know that we can have an appendicitis when our appendix gets inflamed in that right lower quadrant. It's usually identified clinically when you have a white blood count, nausea, and vomiting, and rebound right lower quadrant tenderness. On a KUB, we can see an appendicolith, which would be typically a fecal lith or a stone stuck in the appendix. On ultrasound, we see a non-compressible appendix with hyperemia or extra blood flow because it has so much inflammation. CT, you can find a round or oval mass. Now, these do have the probability that they can rupture and cause either an abscess or peritonitis, and so these need to be surgically removed as soon as possible. Diverticulosis is the presence of diverticuli in the colon, that's outpouching of the mucosal layers. Fecal matter and seeds and different things can be trapped in these outpouches and cause some inflammation, and that's when this would become diverticulitis. Diverticulosis usually happens in segments of the bowel or little clusters. Diverticulitis can happen when those clusters get irritated. Okay, ulcerative colitis. This is going to be ulcerations throughout the whole colon. Usually these ulcerations are pretty superficial. This can be differentiated from Crohn's disease in that it affects the whole colon, not just patchy areas like Crohn's disease does. It's more common in the sigmoid and rectal area. It can also be associated with a lot of abscesses and fistulas. People with ulcerative colitis, remember, are at 10 times higher risk for having colon cancer eventually. Crohn's disease, just like it was in the small bowel, is going to have patchy effects in the large intestine. It's usually going to be most common at the cecal area. It can be evaluated with BE, and you'll see that patchy distribution or the cobblestone appearance with skip lesions or normal bowel in between those. Ischemic colitis can affect the entire colon. It can have one part of the colon. It's going to have fine superficial ulcerations due to a lack of blood flow to that area, and it can provide that characteristic thumbprinting appearance that we saw on the image we looked at just a few minutes ago. For this, immediate surgery would be required. Okay, irritable bowel syndrome. This is alteration of intestinal mobility, so they'd have some times of high mobility and experience diarrhea. Other times they would have very low mobility and experience constipation. So no cure exists, but diet changes, medications, things like that may help the symptoms. Colonic carcinoma is most often in the rectum and sigmoid region, having polyps or having diverticuli or having ulcerative colitis can all contribute to your probability of getting colon cancer. It's one of the more common cancers, and it typically has either an apple core appearance or a napkin ring appearance. And anytime you have a polyp that's greater than 2 centimeters and has no stalk, you're on higher alert to be identifying a colon cancer. Large bowel obstruction can happen from a volvulus, where the bowel twists on itself. anytime there's something lodged in the bowel, anytime perhaps a mass occludes the lumen of the bowel, any of those occurrences can cause a large bowel obstruction. We just talked about a volvus as being the twisting of the bowel. Hemorrhoids, we know, are dilated veins in the rectal area. Clicker questions really quick. Inflammatory bowel disease includes Crohn's colitis, diverticulosis, ulcerative colitis. Diverticulosis is not an inflammation, it's just the presence of a diverticuli, so this would be 1 and 3. Colon cancer is the 3rd leading cause of cancer deaths in the United States. This was true. Okay, so with our gallbladder pathology, we're really going to think about what the gallbladder does. And if this is my liver, my gallbladder sits right in kind of the porta hepatis area of this liver. And it has a neck, a body, and a fundus. And what happens with the gallbladder is out in the periphery of our liver, we have a lot of what we call hepatocytes or liver cells. And those liver cells are going to produce bile. Bile then is dropped into these little tiny biliary ducts that all travel towards the center of the liver. And as these little bitty biliary ducts travel towards the center of the liver, they come together in slightly larger biliary ducts. They're very small still. As they get towards the porta hepatis, they all kind of congregate in this one hepatic duct. That hepatic duct communicates with the gallbladder through the cystic duct. And that bile that's coming into the hepatic duct can get shunted and go into the cystic duct and end up in the gallbladder. At that point, the gallbladder kind of holds onto this bile and it causes it to absorb some of the fluids out of it and condense the bile a little bit. When somebody goes and eats a meal, it produces this hormone called cholecystokinin, which causes the gallbladder to contract. When that gallbladder contracts, it's going to push bile out into the rest of the biliary tree. So the biliary tree, if we look at where it goes from the gallbladder, we have our cystic duct, that the bile will go through the cystic duct, meet up with the hepatic duct, and it'll at that point create the common bile duct. That common bile duct then goes down to the head of the pancreas, and the head of the pancreas here has a duct from the pancreas called the pancreatic duct, where it picks up digestive enzymes from the pancreas and continues on down. Then it goes into the small intestine. At the small intestine, it's able to deliver bile and pancreatic juices into the small intestine, and those components are what help our small intestine break down and absorb many of the fats, proteins, and carbohydrates that are necessary for our body's function. So in knowing all of this, this will kind of help prepare you to evaluate some of this pathology. So the most common pathology we look at here is gallstones or cholelithiasis. Chole means your gallbladder. Lithiasis, it would be the stones. Okay, so there's 2 major types of gallstones. Most of the time a gallstone will start because in part of that bile production that the liver does is it sends out little salts, and little salts are usually elements like magnesium and chloride and things like that. And those little salts sit in the gallbladder. And as they sit in the gallbladder, they tend to attract cholesterol. And so there's a lot of cholesterol in bile. So if a bile is sitting in the gallbladder for a long time and there's a kind of a rough salt there, the cholesterol will start attaching to that bile and create these cholesterol type stones. And this is going to be the most common type of stone in the United States. Now there can be pigment stones, but these are going to be less common. So we're really going to focus more on the cholesterol stone. Now, there are some things that put people at predisposition for having gallstones, and they can call them the 4 Fs, or some people call them the 5 Fs. So one of them would be female, fat, 40, flatulent, and fair. So what that means is females are more likely. If they're overweight, they're more likely. If they're having lots of gas, that makes them more likely to have stones. fair would mean if you're pale skinned, you're more likely to have stones. And I think I missed one. But that is our predispositions. Those are our classic gallbladder patients. Doesn't mean it's the only people that get gallstones, but it's our classic. Ultrasound is the imaging modality of choice for evaluation of gallstones, although sometimes you can identify these on an x-ray. So here's just a nice little x-ray. You see the gallbladder. These gallstones happen to have some calcifications around them, and you can see them quite well on this image. Here is an example of a gallbladder. This circular area here is a gallbladder on ultrasound. You can see that there's a stone here, and that stone is creating a shadow. That's indicative of a gallstone. One of the problems that can occur with gallstones is that sometimes they can get lodged in those ducts between the gallbladder and the small intestine. And when that happens, they can cause a lot of problems. And so that's one of the main reasons that gallstones or gallbladder, it gets removed. Now, acute cholecystitis is often caused or started by gallstones in the gallbladder, but what this is it means it's an acute or a short bout of gallbladder inflammation. So it's usually caused by some sort of cystic duct obstruction by a gallstone. And that cystic duct obstruction makes it so that every time you eat and the gallbladder tries to contract, it's pushing its bile up against an obstructed cystic duct, and so it is unable to move the bile through. Now that makes it difficult. It causes the gallbladder to get enlarged, but it also causes the intestines to not get the bile necessary to help break down food. So this can be quite painful, and sometimes they'll call them gallbladder attacks. Now, acute cholecystitis can be evaluated on ultrasound. It can also be evaluated by nuclear medicine. So here's an example of a cystic duct that is not allowing the movement of bile from the gallbladder out into the intestines. Here we see where it is moving into the intestine. So this would indicate that, that there is not a lot of movement of bile in that cystic duct. Now, cholecystitis of any kinds, this is going to be inflammation of the overall gallbladder. It sounds like it's not that big of a deal, but it really can be a very big deal. It can cause rupture of the gallbladder, which would then likely lead to hepatitis and peritonitis and all kinds of other things. You can also have necrosis of the gallbladder, which actually can kill a patient. One of the steps in between those two things, you have cholecystitis, but it hasn't ruptured. You might actually get some emphysematous cholecystitis. And emphysematic cholecystitis is when there's inflammation in the gallbladder and it's producing air. Now, if you see a dead deer on the side of the road, lots of times they will look very, very bloated. The reason they're very, very bloated is that the bacteria and other things are breaking down that deer's tissue and releasing air. The same kind of idea is true about emphysematous cholecystitis. You have an inflamed gallbladder and it's very, very sick, and you actually have tissues that are breaking down and necrosing, and they're releasing air because of that. So emphysematous cholecystitis is a very rare condition. It occurs when there's stasis of the gallbladder, so it's not contracting efficiently. There's ischemia, so there's a lack of blood flow to the cystic duct and the stones, and because of those reactions, you start developing gas-forming organisms of the gallbladder. So this is a very sick gallbladder. It occurs most commonly in elderly men and patients with poorly controlled diabetes, because that's going to affect the blood flow to that area. So here's an example of an emphysematous cholecystitis on a patient with an x-ray. And so you know that on x-ray, air looks radiolucent. And so you see this gallbladder here, and you can see that the radiolucent air is in the gallbladder. And then obviously you must have bile in the inferior part of the gallbladder here. The next type gallbladder problem we're going to talk about is porcelain gallbladder. And what happens with porcelain gallbladder is that a gallbladder that's inflamed for a really long time, so we've had cholecystitis for a long time, it's going to start to replace or attract calcium to some of those walls of the gallbladder that have been so angry for so long. And as it does that, the gallbladder almost becomes calcified. So that's why we call it a porcelain gallbladder. If we look at a porcelain gallbladder, you can see this is not a solidly calcified gallbladder, but you can see it is maintaining a lot of calcium. We can also note this on ultrasound, although it can be a little bit challenging. These porcelain gallbladders are highly associated with development of gallbladder cancer, so these need to be removed and taken very seriously. Okay, I'll let you read over the summary of gallbladder diseases and treatments. We'll continue on. So what is the most common cause of acute cholecystitis? It is usually the cystic duct obstruction by gallstones. That will move us to liver pathology. So liver pathology is really an important thing that we see a lot of in our clinical sites. So hepatitis is a common liver pathology. And this is simply inflammation of the liver. Cirrhosis of the liver is a result of long-term liver disease. Hepatocellular carcinoma is also known as a hepatoma, and this is usually a very significant cancer of the liver that is associated with long-term hepatitis and cirrhosis, or hepatic metastasis, which would be tumors of the liver or cancerous tumors of the liver that have gotten there through from another site. When we talk about hepatitis, there's a few different types of hepatitis. Anything that's going to inflame the liver is considered hepatitis. So is somebody taking too much Tylenol, especially people that have tried to overdose, commit suicide through Tylenol overdose, that can cause that can cause hepatitis. Overexposure to too much alcohol for your liver, that can cause hepatitis. But the hepatitis we're most commonly hearing about is usually due to our viral infections, hepatitis A, B, C, and E. Now, I heard this great mnemonic one time that says, with viral hepatitis, if it starts with a vowel, it comes from the bowel. So hepatitis A and E, they start with a vowel, and that means that they are coming from the bowel. So that would mean it was something that was ingested that they got the virus from. So it's from ingesting something with the virus, a person would then have the virus. Hepatitis B and C are different. These are more common. These are the bloodborne pathogens. So these are the hepatitis that you get from exposure to blood, sharing IV needles, sexual contact, things like that. So if it starts with a vowel, it comes from the bowel. If it starts with a vowel, it comes from the bowel. Otherwise, it's bloodborne. Either way, they both are going to have inflammatory reactions in the liver. And what the liver does is when it gets inflamed, it will start to swell just like any inflammation would. So a swollen liver will become very enlarged, and it will take on lots of fluid, and it will attack the inflammatory process. Now, over time, if it attacks that inflammatory process and the inflammatory process wins, then if the attack works and it clears out the inflammatory process, then it would go back to normal, and that would be acute hepatitis. But lots of times, it will have that inflammatory reaction. The liver cells, the immune cells will cause edema of the liver, and the battle will continue and continue and continue, and yet that response of your body trying to clear out that pathogen doesn't work. And when that happens, it becomes chronic hepatitis. And when the liver experiences chronic hepatitis for a long period of time, it begins replacing some of its normal hepatic cells with fatty cells. And then if it continues to experience hepatitis for a long period of time, even after a lot of those cells have been replaced with fat, then it will actually sort of give up and start breaking down and turning into fibrotic cells. And at that point, that's when it transitions from chronic hepatitis to cirrhosis. Now, you guys as healthcare workers are at high risk for hepatitis B especially. And remember, this is a bloodborne pathogen disease, and it's very, very dangerous. It could put you into cirrhosis or liver failure at some day. So most employers are encouraging healthcare workers to get your hepatitis B vaccinations so that you can protect yourself from these types of diseases. Okay, now, like I said, cirrhosis is usually what comes after long bouts of chronic hepatitis. So with that chronic hepatitis, we had inflammation as our immune system fought the pathogen. If it won, if our immune system won, our liver went back to normal. If it didn't win, then the pathogen and the inflammatory process would continue to go on. And after some time, those liver cells try to protect themselves, so they build fatty walls around them, and that's when you might say, I have a fatty liver. If that continue to get assaulted after that, that fat will even start to break down, and those hepatic cells start to give up, and they just kind of atrophy and get really hard and dense and fibrotic, and that's when you get cirrhosis. And when you have significant cirrhosis, your liver has gone from being really big and inflamed to shriveling up like an old prune. Okay. Now, one area of the liver may be spared from this, and that's the caudate lobe. It has its own blood supply and its own blood flow drainage, and so sometimes it can be spared from cirrhosis. Cirrhosis is really an end-stage liver disease. Most patients with alcoholism don't get cirrhosis, but those that do are highly affected by this. Now, one of the things that cirrhosis causes is a buildup of ascites in the abdomen. So as your liver is unable to process the incoming blood as well, it can start backing up blood into different systems like the spleen, the mesentery or the bowel. And as it does this, it starts leaking serous fluid, and that builds up as ascites. These patients with cirrhosis can have a lot of ascites and be almost pregnant with ascites, and that ascites is just free fluid in the peritoneum. They may take on almost a pregnant appearance and be very, very uncomfortable because of the ascites. Now, often, like I mentioned, cirrhosis is caused by alcoholism, but other causes can be post-necrotic viral hepatitis, so it could be the viral hepatitis, hepatotoxic drugs and chemicals, so like the Tylenol overdose would be an example of this. There can be something called biliary cirrhosis, where the bile duct tract is somehow blocked for such a long period of time that bile backs up into the liver and then causes damage to those hepatic cells. And if it's not corrected in time, it can lead to cirrhosis. The most characteristic symptom of this is poor liver function, which would increase in lab values that are very abnormal for the liver, as well as ascites, or that fluid accumulation I was talking about in the abdomen. This is, once it gets to the point of cirrhosis, this is incurable and irreversible. So here's a cirrhotic liver on CT. This liver is still relatively large. Once cirrhosis progresses, it will get smaller and smaller. But you can see that there appears to be some fluid surrounding the liver, so this is in a significant stage. Now, anybody that has cirrhotic liver is at a higher chance of having hepatocellular carcinoma, or this can also be known as a hepatoma. This is the primary liver cell cancer. It's most common in people with cirrhosis. CT modality is the choice for diagnosis for this. They'll have some abnormal lab values and not a great prognosis. So here's an example of a patient with a CT. Here's a large hepatoma or hepatocellular carcinoma. And yeah, you can see it's taking up most of the liver there. Okay, hepatic metastasis is going to occur when you have a cancer or a malignancy in some other organ system that spreads through to the liver. Now, one thing that's interesting about the liver is it has its own hepatic arterial supply that comes from the aorta and gives its nice, clean, fresh, oxygenated blood. But it has a secondary blood supply coming from the portal system. And the portal system actually has venous blood from the spleen and the mesenteric artery that mesenteric vein that gathers blood from the bowels. So the hepatic metastasis is really common because you're getting blood from all different organs that's being transferred into the liver. So hepatic metastasis of different types of cancers can be pretty common. The other way it can be delivered to the liver is through lymphatic spread or through direct extension from a nearby organ. Hepatic metastasis is usually diagnosed through CT, ultrasound, MRI, or nuclear medicine. And once you have a hepatic metastasis, your prognosis is very, very poor, unfortunately. So here's an example of hepatic metastasis on your CT exam and here on your ultrasound exam. Okay, I'll let you read through the summary of the findings of the liver. And click a question. What is the most common malignancy of the liver? And that would be your hepatocellular carcinoma. Which type of viral hepatitis is most concerned to healthcare workers? That's your hepatitis B. B and C are the ones you get through bloodborne pathogens. B is the most common kind we encounter in the clinical site. That brings us to pathology of the pancreas. So the pancreas, as I mentioned, was very closely tied to that biliary tree. In fact, the common bile duct that delivers bile from the biliary tree into the duodenum actually transfers itself right through the head of our pancreas. And so our pancreas has two components. It has an endocrine and an exocrine component. Its endocrine component produces insulin, which goes out and it helps us absorb glucose into our system. Its exocrine component creates digestive enzymes, which gets dumped into this duct that runs down the pancreas. It's called either the duct of Warsong or the pancreatic duct, and that duct joins up with the common bile duct and gives it its digestive enzymes adds those digestive enzymes into the bile duct where it can be delivered into the small intestine at the duodenum. So it has a very important component in not only sugar regulation, but in digestive functioning as well. So some of the pathology that we're going to look at about our pancreas is acute pancreatitis, chronic pancreatitis, pancreatic pseudocysts, and cancers of the pancreas. Acute pancreatitis is inflammation of the pancreas. It's an inflammatory process in which protein and lipid digesting enzymes become activated within the pancreas and begin to digest the organ itself. So some of those digestive enzymes that the pancreas creates is amylase, lipase, and chymotrypsinase. And amylase and lipase break down lipids and proteins and, lipids and fats, and chymotrypsinase breaks down proteins. So when a pancreas gets a little bit inflamed, it can start leaking those digestive enzymes into itself. And when it does that, those enzymes begin eating up the pancreas. Now, what stimulates that initial leaking? Usually it's going to be excessive alcohol consumption. However, other things such as obstruction of gallbladder flow obstruction of bile flow can cause the same sort of reaction. This is an extremely painful situation. People are very, very sick from this with nausea, vomiting, diarrhea, and extreme epigastric pain. Here's a CT of a pancreas, and the pancreas really should take up about this area here. But what you see here is all this diffuse enlargement of the pancreas as it tries to basically digest itself. Here it is on ultrasound, where the pancreas typically just lies right in here like a kind of a lazy little caterpillar, and it's nice and smooth typically. And here you see that it has all of these things that appear like holes. Chronic pancreatitis. Now, usually your acute pancreatitis is self-limiting, and in about 48, 60 hours, it will kind of correct itself. But chronic pancreatitis results when there's frequent pancreatic inflammation. So you've had lots of bouts of pancreatitis, and it causes that pancreas to give up. So any of these pathologies, once you've assaulted a cell over and over and over again, it kind of gives up and starts to fibrose, which is where we get scar tissue from. So chronic pancreatitis has been assaulted so much that the pancreas has just kind of given up and turned to scar tissue. When this happens, it causes the gland to lose some of its ability to produce those necessary enzymes that are important for digestion, or enzyme or some of the endocrine hormones that are important for glucose absorption. This one will have severe pain, malabsorption, and diabetes. Here's an example of chronic pancreatitis where you see that fibrosed or scarred up tissue is turning to calcifications across the patient's epigastric region. Now, there's such a thing called pancreatic pseudocyst, and pseudo means false, and cyst would be a well-circumscribed fluid-filled area. So this pancreatic pseudocyst is a thin-walled fluid collection, but it's not just a harmless cyst. It usually occurs due to inflammation, necrosis, or hemorrhage, which can be triggered by acute pancreatitis or trauma. And so that's why they call this a pseudocyst. Here's an example of a pseudocyst. This one has an calcified encapsulation that's demonstrating this pseudocyst in the tail of the pancreas. Okay, cancers of the pancreas are usually very, very, very poor prognosis. Most of them come from an adenocarcinoma, and the terminology adeno describes glandular tissue. So this would be carcinoma of glandular tissue, which makes sense because our pancreas is just a big gland. So usually these are not advanced early on in the disease stages. So by the time they are diagnosed, they usually have a very, very poor prognosis, sometimes only a couple weeks, but often not more than a year. So most common site that we find cancer of the pancreas is in the head of the pancreas. There are other tumors of the pancreas, but they're not as common. So there can be insulinomas, gastrinomas, or diarrhea islet cell tumors. And islet cells are the ones that produce insulin. So these would be affecting the insulin producing cells. Here's an example of an ultrasound exam. This is the pancreas, this kind of bright looking area. This is the head. And you can see that tissue in the head of the pancreas is very different from the rest of the pancreas. And this would be probably a pancreatic carcinoma. Here we see it in a CT exam, and you see disruption of the shape of the pancreas right here in this mass. Okay, and here's a summary for our pancreatic diseases. So I'll let you go ahead and look through those very quickly. Okay, a few more pathologies that we want to talk about. Pneumoperitoneum. So the peritoneum is the cavity that contains the majority of our organs in our abdomen. And if we have pneumoperitoneum, pneumo means air. So that would be air in the cavity, in our peritoneal cavity. Usually this is going to be caused by some sort of perforation of the bowel, causing the bowel to leak air out of the bowel into the peritoneum. Other causes can be abdominal, gynecologic, intrathoracic, or iatrogenic causes. And remember, iatrogenic causes mean that we don't know why. But if there is a perforation in the bowel, then this needs to have surgical repair immediately as to avoid causing peritonitis. Here's an example of pneumoperitoneum, and this is one of the great examples of why we try to do all of our chest x-rays in an erect or upright position. Here is the diaphragm. Here you see air beneath the diaphragm, and it's not contained in the stomach. So you know that this is free air underneath the diaphragm, which would be pneumoperitoneum. If your patient was so ill they could not stand up or sit up for an extended period of time, then you could always obtain these air fluid levels in your decubitus positions. Okay, what's the most common site of pancreatic cancer? That was in our pancreatic head. What is the most common cause of acute pancreatitis? That is typically excessive alcohol obstruction or consumption, although gallstone obstruction bile flow can be a secondary cause. That brings us to pathology of the spleen, and the spleen fortunately is a fairly simple organ. So one of the things the spleen does is it has a component of it that it clears out and cleans up our red blood cells. So that's one component of the spleen. The other component of the spleen is that it has a lymphatic type component that takes part in some of our immune responses. So when we look at those processes of the spleen, it can describe why sometimes we'll see enlargement or even rupture. So splenomegaly, megaly means large, so splenomegaly means that might have a large spleen. It's usually associated with infective type conditions. One of the most common is mononucleosis, but it can be associated with tuberculosis, bacterial endocarditis, malaria, other things like that. So an enlarged spleen could indicate that there is a significant pathology going on throughout the rest of the body, and we're just seeing it as an enlarged immune organ. Other things that can cause it to become enlarged is connective tissue disorders. Because it contains a lot of lymph, lymphoma or leukemia can cause it to enlarge. It cleans out our red blood cells. So hemolytic anemia, meaning that I have too much red blood cells and the spleen's trying to clean them out, can also make it large. Hemoglobinopathies can make it large. And then the last one, which is really fascinating, is portal hypertension caused by cirrhosis, which can make it large. And the way that that happens is, here's our spleen. It has its own splenic artery, and it has a splenic vein that comes out and goes over here. That splenic vein is going to join with a vein from the bowel that just went and it collected a bunch of nutrients from the bowel and it brought it back to this point. And these two are going to join together at this called the portal splenic conference, and it's going to develop or send out the portal vein. This portal vein goes right to the liver to provide the liver with all kinds of nutrient-rich blood. Now, if I have a really sick liver, just like we talked about it, and it's very cirrhotic, and it's hard, and I'm trying to push this blood in here, and it can't get in there because this liver is so hard, that blood's going to start backing up into this portal vein. And then as it backs up to the portal vein, and the portal vein gets as full as it can handle, then that blood's going to start backing up into the splenic vein and the superior mesenteric vein. And those veins are going to get so full that they can't drain their own organs anymore. And when that's the case, then your spleen becomes larger and larger and larger. So here's an example of splenomegaly on your CT exam. Here is the right side of the patient. So this is liver. Over here is the spleen. And it just looks very rounded, full. And if you measured it, it was major enlarged. Usually anything over about 12 centimeters of a spleen is considered enlarged. Now, one of the things the spleen can do is rupture. The most common cause of splenic rupture is usually trauma, like a car accident or something. The problem with splenic rupture is that it can result in a lot of blood loss. Now, splenic rupture may also be more common when you have splenomegaly and the spleen is already enlarged and kind of pushed to its limit. Then it's more likely to rupture with less trauma. So here is an example of a splenic rupture. Here you see the spleen, and you see that there is this perfusion or blood outside of the spleen, and that is caused by the splenic rupture. So you can look through the summary of our splenic disorders here. And that will wrap it up for today. I know it was a very long lecture, so I appreciate your time, and I hope this helps you understand some of the pathologies in the abdominal system or digestive system. Okay, thank you. Have a great day.